Hello, this is Nancy Capone. I'm here today to discuss with you the concept of perfusion. I wanted to mention that the concept of perfusion is interrelated to many, many other concepts. There's probably more than what's listed on this slide, but it's pretty much if you don't have perfusion, you don't have a living, breathing person to take care of. Perfusion is adequate flow of blood through arteries and capillaries that deliver nutrients and oxygen to cells and remove cellular waste products. Think about what the goal of perfusion is. Think about how you would assess for adequate perfusion, and what signs and symptoms would you look for inadequate perfusion. Again, it depends on the body system or body part that is affected. The goal of perfusion, there's actually two. Because you have central perfusion and peripheral perfusion, the goal of peripheral perfusion is to maintain adequate arterial blood flow through to the peripheral tissues. Likewise, with central perfusion, blood that is pumped by the heart to oxygenate major body organs. So those are your the heart's ability to adequately supply blood and nutrients to the body, and the patency of the arteries to adequately supply blood to all body tissues. So as you can see here, perfusion is related to the cardiovascular system, the heart as a pump, the vasculature as a delivery system, and blood volume. So you have to have an adequate pump. You also have to have adequate delivery system, means intact arteries. You have to have enough hemoglobin. You have to have enough oxygen that's saturating the hemoglobin. You have to have enough nutrients, etc., and deliver it to the tissues that are needing it. Some of the risk factors I've listed on here, medical conditions that could affect perfusion and increases the person's risk for having decreased perfusion, and very, very similar to cardiovascular risk factors. There's modifiable risk factors like smoking, you need to quit smoking, sedentary lifestyle, lack of exercise, obesity, etc. These are things that person can change to make their risk go down. But non-modifiable would be somebody's age. Middle age and older adults are at higher risk for decreased perfusion, and infants with congenital heart disease are also at higher risk. Gender, males have a little bit higher risk than females for decreased perfusion issues, and genetics or family history. In our country, African Americans have a higher risk of developing decreased perfusion issues. And I've listed some of the medical conditions on there. Basically, hypertension related to arterial sclerosis and peripheral vascular disease. Diabetes increases the risk of atherosclerosis developing. Hyperlipidemia and obesity also increases the risk of atherosclerosis. Decreased perfusion could be one of two things, ischemia or infarction. Ischemia is decreased blood flow or impaired perfusion to an organ or body part. It's a lot of times reversible, but it's not always reversible. And then infarction is actually tissue death. So you can't get that tissue back. It doesn't grow back. Ischemia results in tissue damage, and the ischemic cascade is activated. Damage occurs due to the buildup of metabolic waste, inability to maintain cell membranes, mitochondrial damage, and eventual leakage of autolyzing, which means they eat themselves, proteolytic enzymes into the cell and surrounding tissues. This peripheral perfusion decrease often occurs in the lower extremities, and we'll talk more about that in a minute. And decrease in central perfusion is usually related to a life-threatening systemic event such as an acute myocardial infarction, stroke, and shock, with decreased blood flow occurring to the major organs. Impaired central circulation, which I just briefly talked about, what happens with that, if you have a decrease in central perfusion, this is going to affect major organs. Cardiac output goes down, and then you have systemic results and symptoms, and it increases the reduction of circulation, leading to a shock state and then eventual death. At the local level is interference with cell perfusion, so they're not delivering it where it needs to go or not delivering enough. This reduction in flow allows through the capillaries into the interstitial spaces, which decreases delivery of oxygen, fluid, and nutrients to the cells. It's leaking out around the cells. Also, you have an increased systemic vascular resistance if you have impaired central circulation, which causes the blood vessels to constrict, which increases the systemic vascular resistance, causing the heart to work harder. The heart may fail. Blood gets thicker. Could be thicker, I'm sorry. That will also increase the SVR. And it could go the other way, reduction in systemic vascular resistance related to vasodilation or to blood loss. There's just not enough volume to circulate. This will also cause central perfusion to decrease. Cardiac output is reduced with the central perfusion impairment, including, it could be because of inadequate perfusion to the heart muscle itself, like with coronary artery disease, inadequate impulse conduction through the heart with arrhythmias, heart blocks, malfunction of a heart valve, or occlusion or constriction of coronary arteries. So if you actually do have an infarction in a coronary artery, it's going to cause loss of blood to the area of the heart. Depending on how big that blood vessel was, it may affect a very large area of the heart, which will increase the impairment of the central perfusion, kind of like a snowball effect. And I mentioned the local tissue peripheral perfusion impairment, and it's causing a lack of nutrients being delivered to the periphery. Causes tissue damage. So tissue perfusion is impaired because of decreased blood flow. Causes reduction in blood flow through capillaries, again into the interstitial spaces. Poor central perfusion or from something wrong within the organ itself, which is a cumulative effect. You could have a blocked blood vessel to or from the tissue, or from swelling or edema. This interferes with cellular oxygenation, increases the pressure and associated constriction or collapse of the arterioles going to the peripheral organ, and that will cause tissue and then organ death and finally body death. Interesting, brain and intestines require larger blood volumes, so they're the most easily affected when you have impaired peripheral tissue perfusion. Atherosclerosis or thrombi can occlude arteries. Additionally, thrombi can occlude veins. You could have vasoconstriction. I mentioned nicotine as one cause, but there's also frostbite, not so much in Georgia. And there are some medications that deliberately constrict blood vessels. For example, if you're in a shock-like state and you're being given vasopressors, which increase the blood pressure, and they do that by clamping down on the periphery. And that would be an example of a medication that causes vasoconstriction. There's also medications, a lot of the antihypertensives that cause vasodilation, but also physical conditions such as aneurysms and varicose veins. Impaired perfusion, there's kind of a summary of them, so you can keep in mind if they do have impaired perfusion. These are some of the more common conditions that lead to that. Exemplars for the local tissue or peripheral, and you can see a lot of this is things I've already mentioned. The only new thing on there is the Raynaud's disease, and just so you know what it is, you're not tested on this. This is a rare disorder of blood vessels that usually affects the fingers but can affect the toes. And what happens is intermittently the blood vessels narrow when you're cold or feeling stressed. And when this happens, blood can't get to the surface of the skin and the affected areas turn white and blue. When the blood flow returns, it is very painful. The skin will turn red and the fingers or toes will throb and tingle. And in very severe cases, loss of blood flow can cause sores or tissue death, like in gangrene. The cause is not known. So how do we assess tissue perfusion? Central perfusion, you're looking at the heart rate, blood pressure, including orthostatic blood pressure, and hopefully you've learned that in your health assessment course. Orthostatic blood pressure measurements can tell you a lot about the volume, fluid volume of a person. So it's done for many, many different reasons. Even diagnosis of dizziness when they don't know the cause, that would be something you would look for. Maybe they're a little dry or fluid, have fluid deficit. Something else you can look for is abnormal heart sounds. Remember S3, S4, and then murmurs, which are caused by turbulent blood flow. That could be because of a heart valve malfunctioning, which could decrease central perfusion. It could be because of higher viscosity of the blood flowing through the heart, or maybe it's some other defect that's causing abnormal blood flow through the heart. You want to look for altered mental status, shortness of breath, irregular heartbeat, swelling in the periphery, diaphoresis, anxiety. It's a little bit harder in infants and small children. What you can look for is a low birth weight or low not gaining weight or failure to thrive. Some infants will have a weak suck. They will have shortness of breath while feeding. An infant that is, or a small child that is less active than other children their same age. And they may have alterations in their pulses, either between the arms or between the arm and the leg. In the periphery, a little bit easier to see if it's on the legs, most commonly in the lower extremities. And some of the things that you look for is lack of hair, brittle nails. The skin can be all different colors, pale, cool, darkened or discolored, as in this picture. Diminished to absent pedal pulses, and this is both pedal pulses. This could be the dorsalis pedis and the posterior tibial pulses, or both. Could diminish and then are absent. They would have pain and discomfort, numbness or tingling. And remember your 6 P's when you're assessing extremities. I'm going to have you look that up if you don't already know it. Sometimes there's peripheral edema, especially if there's backup in the venous system. And most important, prolonged capillary refill time. Don't forget that. That is so important when you're assessing perfusion. Sometimes the skin will get a rubor, R-U-B-O-R, which is a sign of arterial insufficiency. And if you've ever seen that, you'll know it's just reddened. Also, the skin, the texture is tougher. Sometimes they have dry scaling skin ulcerations, and definitely poor turgor. In the kidneys, the urine output may change and decrease. You have RAA stimulation, and you may again have peripheral edema, just to the kidneys not getting rid of fluids like they should. In the brain, it just depends on the area and extent of ischemia or infarction. They could have weakness, they could have altered mental status, paralysis, they could have a transischemic attack or TIA, and general orientation issues. The GI and GU tract may also be affected, and that would lead to changes in how they normally are functioning. Some of the diagnostic tests are related to the organ or organs affected. So the enzymes, isoenzymes, and biomarkers, it just depends on organs. I mean, yes, you can look at creatine kinase when you have muscle damage. You can look at the BNP, the natriuretic peptides, for heart failure. You can look at troponin, also for heart muscle damage. Homocysteine, not really used anymore. It's not specific for any one organ. They used to think it was, but it's not, so you don't have to remember that one. But C-reactive protein is another one, and serum lipids is another. They have the creatine kinase have isoenzymes that are a little bit more specific. For example, you have CKMB or myocardial band. That's myocardial tissue. If that's elevated, then you've probably had a heart attack. There's also CKMM, which is muscle tissues, and they have a CKBB, which is brain tissues. Some of the other tests, again, related to the organ. Electrocardiogram if the heart is involved, stress test for the heart, ankle brachial index for the peripheral circulation, chest x-ray, ultrasounds, CAT scans, arteriograms, all of those could be used in trying to diagnose the issue that's causing the perfusion, inadequate perfusion. Treatment, again, depends on what is affected, but number one, and this is for cardiovascular disease in general, prevention, prevention, prevention. I don't know how many times I can say that. So primary prevention. And this can be for you or your family members or your patients. Health promotion and prevention of disease. There's a box 18.1 on page 173 that describes the American Heart Association health promotion recommendations for all people. There's also secondary prevention or screening, especially if you have genetics that indicate that you may be at risk for developing some of these problems. A lot of times with hypertension, because I mentioned that it's a silent killer, they may have no indication that they have a problem until an end organ is affected, like the heart or the kidneys or the lungs or the peripheral artery disease. These are, but a lot of times you'll go have a checkup at your doctor's, maybe with or without symptoms, and he takes your blood pressure and the blood pressure is elevated. It could be something that simple. Doesn't often happen like that though. But think about triglyceride and lipid screenings, diabetes screenings, blood pressure screenings, all important secondary prevention tools. Treatment, very generally, you want to treat and manage the cause. Good nutrition, stop smoking, control conditions like hypertension, diabetes, hyperlipidemia. I've listed the pharmacotherapy, and it's varied. Again, it depends on what the issue is or what caused this to happen. There's also procedures and surgical interventions, which I've listed on there. So there's a lot of things that can be done, but this is usually after the damage has occurred. Geriatric considerations, again, Vascular changes occur with aging. For example, large arteries stiffen, or you get arterial sclerosis, which causes an increase in afterload, increase in cardiac workload. As you age, your cardiac output decreases by 30 to 40%, so it won't take much for your body to decompensate or for the or for perfusion to be affected, because you've already reduced the cardiac output by 30 to 40%. Less body system reserves, which means you have less tolerance to stressor. A lot of older people, especially on blood pressure medicines, develop orthostatic hypotension, which causes a lot of problems in and of itself, including trauma from falling. Very high risk of that the older you get. Pediatric considerations. The heart is larger in the chest in relation to the total body size. The systolic blood pressure is lower than in adults. The arteries and veins lengthen to keep up with body growth. So anatomical and physiological difference in the cardiovascular system will affect the pediatric response to and compensation for alterations in the cardiovascular system. One of the things that I've mentioned in another lecture, that the heart in a pediatric infant or small child, is that they don't have the ability to increase contractility. All they can do is increase heart rate. So a lot of times when there is impaired perfusion in a small child, what you're going to see is these outrageous heart rates over 200, because that's the only thing their body can do to compensate for impaired perfusion. Just something to think about. And I thank you for your time. Please let me know if you have any questions.